Well, in this week's Cardiology Countdown, we have two articles appearing in JACC. The first beginning with novel ways of imaging plaques to look at activity. And this study looked at sodium fluoride as well as fluorodeoxyglucose, or FDG, using PET imaging of plaques. Interestingly, the sodium fluoride looked very good in terms of reproducibility and differed between patients who had known atherosclerosis versus those who did not, a little over 100 patients in this study. The FDG analysis had a lot of glucose uptake in the myocardium and prevented looking at the plaques themselves, and so that was a little bit more difficult for the coronary uptake. And so this would be a potentially novel way to look at activity of the plaque, where in theory these would be the vulnerable or active plaques, but obviously needs much more validations. At the number 2 spot, we have another article in JACC that is the TRIGGER-PCI trial. This addresses the hot topic of the non-responders or low responders to clopidogrel. And so they studied elective PCI patients. The study was stopped early and largely for futility with low event rates, which is good news for the patients. But 212 patients with elective PCI tested with the Verify Now platelet assay found to have high residual platelet reactivity and were randomized to the standard treatment clopidogrel or prasugrel. They saw dramatic change in the platelet function with great platelet inhibition or greater platelet inhibition with prasugrel. But very few events. Cardiovascular death MI occurred in just one patient on clopidogrel and none for prasugrel. A broader endpoint, including recurrent ischemia, was 6 events versus 2, and so a favorable hazard ratio, but obviously not significant. And so this strategy looks promising to correct the lack of platelet inhibition or low platelet inhibition using a stronger agent, but would be seen potentially in higher risk patients that this would be potentially relevant. At the number 1 spot is an interesting look at weekend admissions for Afib, where, not surprisingly, patients admitted on the weekend had only about half the chance of having cardioversion as those who were admitted during the week. But of concern, they also had a higher adjusted mortality, about a 25% higher risk. There were differences in comorbidities, etc., but when trying to correct for that, it did look like a weekend admission was an adverse prognostic sign. And so something for us to look at and see, do we need to make sure to do things more similarly on the weekend in order to ensure good outcomes? So for this week's Cardiology Countdown, I'm Chris Cannon.